Welcome to MLT Case Study 7. So today's topic is G6PD deficiency, a false positive result in an unknown patient. So this case study delves into the complexity surrounding a false positive result for glucose 6-phosphate dehydrogenase deficiency. So this is underscoring the critical importance of accurate diagnostic practices. G6PD deficiency is a genetic disorder affecting red blood cells leading to episodes of anemia. However, false positive can lead to unnecessary worry and inaccurate management strategies. Through this case, we will explore the implications of diagnostic accuracy and steps taken to ascertain the correct diagnosis. So a quick review of G6PD. So G6PD enzyme is responsible for suppressing the free radicals forming inside the RBC, and also it will form glutathione, and glutathione will maintain the cell wall of the red blood cell. So in case of G6PD deficiency, the enzyme will be deficient and there will be increased production of reactive oxygen species, and this reactive oxygen species will damage the red blood cells. So in order to prevent this ROS destruction of red blood cell, the G6PD will play a vital role in maintaining the cell wall integrity of the red blood cell. So let us go deep. So objectives, what viewers will learn. The viewers will understand the clinical significance of G6PD deficiency testing. The viewers will recognize the potential for false positive laboratory tests and their impact. They will learn about the diagnostic approach to confirm or refute initial lab findings, and they will grasp the importance of comprehensive patient assessment in forming a diagnosis. So today's patient background. So the patient is a 25-year-old male with a relevant history of neonatal jaundice, presenting with mild jaundice to fatigue. So he is a male and he has a history of neonatal jaundice and no hereditary conditions has been found in the patient. So clinical presentations include, apart from neonatal jaundice, the patient has no any contributory medical history, but upon physical examination, the patient reported a week-long history of increasing fatigue and noticeable jaundice. Physical examination revealed slight scleral icterus, that means yellowing of sclera of the eyes, and there is no splenomegaly has been observed in the patient. By seeing this yellowing of eyes, we suspected patient might have some G6PD or any other hereditary conditions. So the diagnostic approach, the tests ordered include CBC count, liver function test, direct and indirect bilirubin levels, and G6PD screening has been done. So these tests are selected to assess the patient's hemolytic status, liver function, and specifically screening for G6PD deficiency. So the initial findings showed mild anemia in the patient, and LFT and bilirubin levels were within normal ranges. So the bilirubin and the LFT are normal, but there is a slight mild anemia has been seen. So except for slightly elevated indirect bilirubin has been seen, but the G6PD test also showed positive. So the G6PD test also showed positive. So the positive G6PD test suggested deficiency, which could explain the hemolytic anemia and jaundice. However, considering the patient's overall clinical picture and normal bilirubin levels, there is a chance of possibility of false positive was considered. So what we did, apart from this G6PD test, we also went for checking the peripheral blood smear of the patient. In case of G6PD deficiency, there will be presence of Hen's bodies and there will be presence of bite cells and spirocytes. But surprisingly, the patient haven't shown any bite cells, spirocytes and Hen's bodies in the patients, indicating this might be a false positive in this case. So the differential diagnosis, we have done hemolytic anemia due to G6PD deficiency, and other causes of hemolytic anemia include autoimmune hemolytic anemia and hereditary spherocytosis and liver diseases. The initial positive G6PD test pointed towards G6PD deficiency, but the patient's history and lack of acute hemolytic episodes necessitated further investigation to rule out other causes. So the final diagnosis, further testing including a quantitative G6PD assay and repeated screening for a few weeks revealed normal G6PD activity, leading to conclusion that the initial test was a false positive. So the treatment and management, no specific treatment was required once G6PD deficiency was ruled out. The patient was reassured and emphasis was placed on monitoring for future symptoms indicative of hemolytic anemia. So why a false positive came in this patient? Maybe due to test limitation. The screening test of G6PD deficiency has inherited limitations including sensitivity to sample handling and environmental factors, patient conditions, absence of G6P acute hemolysis symptoms and normal bilirubin levels conflicted with typical G6PD deficiency presentation. Confirmation testing, subsequent quantitative G6PD assay showed normal enzyme activity contradicting the initial screening result. The key takeaways of today's case study: diagnostic accuracy. It emphasizes the need of confirmatory tests to ensure diagnostic accuracy. Clinical correlation. It highlights the significance of correlating lab results with clinical presentation, and awareness of limitations underlines the significance of being aware of the limitations and potential for false positives in diagnostic tests. So today's outcomes. This case highlights the importance of considering false positive results, especially in context of G6PD deficiency testing. It emphasizes the need for confirmatory testing and comprehensive clinical evaluation before making a definitive diagnosis. Relevance to practice. For MLT professionals, this case underlines the critical role of lab testing accuracy, the potential for diagnostic errors, and the importance of thorough understanding of specific tests and sensitivity. It also showcases the necessity of integrating clinical findings with laboratory results to ensure accurate patient diagnosis and management. Thank you so much.